is just a huge honor for me today to be podcast interviewing Dr. Paul Botha all the way from Cape Town, South Africa. It's 10:45 in the morning here in Phoenix, Arizona, North America. What time is it on the other side?
Well, we are now at 7:45 in the evening.
Okay, 7:45. So what time is your bedtime? I need to know when I should cut this interview short so you can go get your beauty sleep.
I'm going to push it a little. I'm going to push it a little tonight for you.
All right. So let me read his bio. He's in private periodontal practice in the northern suburbs of Cape Town, South Africa, in a multidisciplinary specialty practice providing periodontology, implantology, oral medicine, and orthodontics. He finished dental school in '89 in Cape Town, completed postgraduate diploma in special care dentistry in '95, completed 4-year residency program in Oral Medicine and Periodontics at University of Stellenbosch in Cape Town, completed Masters of Medical Science in Clinical Epidemiology in 2013 at University of Stellenbosch Medical School, has been busy in dental politics for many years, serving at national council level and being local branch president. He started, the reason I got him on the show is because I wanted him to come on and talk about his website, findmyimplant.com. It's a global dental implant registry. After entering your patient's dental implant details after surgery, the system automatically sends the patient an email with details on how to log on to see their dental implant details. In the future, months to years to decades, this info may be required to deal with troubleshooting in a quick and efficient way, make the crowns on implants that were placed a while ago, have a new prosthesis made after many years. The patient provides the new attending dentist with their email and PIN for all relevant dental implant info to be assessed. For the dental implant surgeon, it assimilates all dental implant data into an easy-to-access system and provides a facility to upload an x-ray from the day of placement and to send an email to a referring colleague, thereby communicating all the relevant implant data to the restoring dentist. If the restoring dentist is registered on findmyimplant.com, then the patient details will be automatically added to the registry of the referring dentist. If the restoring dentist is not registered, then the system will prompt the restoring dentist to register for free. Once the restoring dentist loads the restoration data, they automatically email system to the patient is initiated. If the patient agreed and gave consent, an annual email is generated to the patient to encourage follow-up. 2 further emails are generated to the patient, one at 3 months post-restoration placement to inform the patient of the relevance of optimal plaque control methods. The second email is generated at 6 months post-restoration to remind the patient of the importance of regular dental hygiene visits. These emails have reply functions to the office of the dentist who placed the restoration. Registration is for free, as are the first 3 implant entries. Therefore, the system will prompt the user to an annual subscription. That is amazing. You know, healthcare really needs to go digital. I mean, I look in the United States. These people go to 5-6 different physicians, dentists, specialists, pharmacies. None of that information's in one place. And then when grandma's at the grocery store and collapse, and they call an ambulance, when the ambulance gets there, they're lucky to know her name. They don't know any of her medical history. They don't know anything about her. So doing what you're doing is getting global information into the cloud so that we can treat our patients better. That's really the future, isn't it?
Well, you know, exactly. Having been involved in placing implants, restoring implants for 25 years now, anybody who watches this podcast will know that they've been through a scenario where a patient reports for some troubleshooting, and now they've got to identify what system is it. So what do? They take a small X-ray, and now they're going to ask who they're going to ask. They're going to ask the dental rep. They might ask another colleague, and in the meantime, the patient still has this problem. We do know that there are what implant is out there which have X-ray databases which you're going to compare it to. So that they have their role in trying to identify all the implants that were placed before we've launched our product. So what we're saying with our product is it's time, with the millions of implants that are placed each year, it's time that we take responsibility for patient data. And if you look at the dental implant industry every year, and you look at things like the top 20 dental implant products, what are they? They're all dental implant hardware. And that's where it ends. So we're saying, but listen, we've got all this data now after the fact, and we're just letting it go out there, and we're sort of accepting that we're going to struggle with this later. So we're saying to the ethical, well, I see it as the ethical and responsible thing to do, to provide patients with access to their own dental device information, so they can go out into the world, and at any time when they do have a troubleshooting, or as you know, some people have dental implants placed, and then if only a few years later have the crowns done, or someone, we're placing implants now in people who in 20 years' time are going to need replacement of those prostheses. Where is the data? So this system gives the patient the ability to have control over their own data. It is a big mind switch for dentists out there, because we have been struggling to get traction with dentists, because it really is a big mindset. It's a little bit of extra administration, but the advantages are just so obvious. And I've loaded now about over 100 patients in my practice in the last 3 months, and the patients are so enthusiastic. They understand it. They understand having control over their own data. So if you want me to just run through that system again, the only data we put online is the patient's name, the patient's email, and their date of birth. That's it. So as soon as I then enter my first implant, the system automatically generates this email to the patient. The patient receives it on their device, and by following a few steps, they log on and get their own code. So they go then forward into life knowing their own email, and they picked an easy pin, say 1,000. So they have an implant placed in Arizona, and now they're in London and they require troubleshooting, and they can see the dentist and say, look, all my data is on findmyimplant.com. If the dentist is not on there, he registers for free. He enters the patient's email and code, and all the data relating to those implants, plus uploaded clinical photos or uploaded x-rays, are included, plus the URLs of the company is there as well. So it makes for easy and efficient help to that patient in times of troubleshooting or otherwise. So there are one or two other nicely built-in things, and that is, for example, the follow-up system. So for any dentist, I see, is this your...
That's Zelda. She doesn't like it when I'm looking at the computer and not Zelda. She's wondering why I'm not paying attention to her.
So let me look at one or two other things in the system, which is nice, and there is the follow-up email system. So for dentists, and many dentists are renowned for not having a follow-up system or efficient follow-up system. So what this follow-up system does, it recognizes the year after the placement of the implant, automatically sends a reminder to the patient, and in that reminder, it's an interactive email where the patient can then see, yes, I would like to go for a follow-up. Just press the interactive button. The email goes back to the dentist's office, and they contact them for follow-up. So, and then there's a patient analytics page where we look at, you can look at your whole practice and see the demographics according to gender, according to age. And there's also some details relating to the various areas that have been restored. So this type of information can give one a nice brief overview of your practice and the specific areas which you're tending to restore more. And that type of information could be used to possibly to guide your own continued professional development activities into a certain area. You might see that I'm actually restoring upper sixes, and my practice quite often, and I possibly need to extend my my skills into sinus lift procedures, whether it be lateral window, whether it be vertical. So yes, so coming back to the So coming back to the whole concept, what I refer to as post-implant placement data analytics. You know, we've got the company, for example, again I refer to what implant is that because people know them. They will still have a role to play for many years because there are millions of implants out there which haven't been placed on our system, but we've got to look forward. We've got to look forward and we've got to empower our patients with the data relating to their own medical devices. You know, so for us as a company, long term, we would be looking at the medical side of things. You know, so any medical device which you have placed, be it a cornea, be it a pacemaker, be it a stent after angioplasty, or be it a knee replacement, we see it as ideal for that patient's data to be recorded as well, so that when they're traveling anywhere in the world, you know, sometimes you're traveling in countries where there is a language barrier. But if you can give it the attending physician your email and your PIN, and he goes online, once again has immediate access to the data relating to your medical device, and can therefore, in a much more quicker and efficient manner, help you as patient.
So I love the YouTube video that you have on your site. Find my implant. Do you care if I have Ryan splice that in right
Yeah,
now?
no, please
Ryan, let's
do.
do that. When did this company go live? It's 2016 right now. When did it go live?
We've only been live for 6 months,
You know,
and
the reason I asked is because do you did you get this inspiration when you went back to school and got a master's in clinical epidemiology? Was studying epidemiology kind of the roots of this brainchild?
uh, no, the brainchild is, you know, this is something I've been experiencing obviously in 2 decades of dental practice. You know, I work with some dental reps here in Cape Town who have been in the business for also a couple of decades, and one rep showed me his book from 20 years ago, where he would write down details relating to patients. Um, so if they phoned back in a few years, he'd have some data. And we all know this problem. And 2 years ago at the inaugural meeting of the South African Academy of Osseointegration, I spoke to a few people, and their enthusiasm sort of spurred me on to go over to action. And so, I mean, it's a program I've designed. I'm not a coder, but so we have a coder on our team, and we have some overseas investment from London, because it's taken up to this stage, you know, quite a bit of money to develop it. I mean, things like this, the video we're going to see, does cost a bit. Yes, so it was just out of frustration, and just I could see, you know, we're not doing the right thing for patients. We're sending them out into the world with, and so as you know, I mean, many implant cases are complex, you know, with loads of detail relating to the fixtures themselves, relating to the abutments that are used, relating to the screw head configurations. You know, something is, so I mean, talking about screw head configuration, something as straightforward as that. If you get someone from another major city, now you've got a mobile implant. You can see it's screw retained, but you don't know what screw head confirmation you're going to find when you open that up. But now you do with findmyimplant.com, because you enter the restorative details as well, and those type of details are included. You know, so this patient comes into your office. If they're registered on findmyimplant.com, you enter the email, you enter the details, and everything will pop up, even screw head configurations, making it easy to access and help the patient.
Well, the reason I asked about your epidemiology background, because this will also be great epidemiological information. I mean, I see implant companies advertising that they have a 98.4% success rate, and it's like, you know, they just throw numbers around. I mean, what does that mean, a 98.4% success
Yeah.
rate? But how many dental implant companies do you think there are now on planet Earth?
Well, I mean, I've heard stories that just in certain European companies, there are hundreds alone, you know. Um, so, you know, obviously there are many hundreds. If I'm going to commit to a number, it'll be a bit of a thumb suck. But, you know, this is even more important to use this system, you know, because there's so many companies out there as well. The clinical epidemiology part, yeah, that was a course that changed my life, you know, looking at research and how to put together research, and has helped shape my thinking as well as to, because findmyimplant.com is our MVP, it's our minimal viable product that we went to market with. So from there on, you know, I have certain ideas and extra modules to develop for companies, where we could have a company module developed and the patient giving consent for this data to, as it gets entered, to be sent to companies as well, so they could have continuous live data relating to all their implants that are being placed. You know, so our options are endless. We can write whatever we can imagine, whatever we can envisage. But at the moment, the important thing is to try and convince our colleagues that this is the way to go, and this is a difficult thing. It's a it's an ethical mind shift which has to take place. I spoke to a colleague at a congress not so long ago, and he said to me, Paul, why should I do this? You know, I've placed the implant, the patient can pay for this. You know, I don't think I should do this. So, you know, I could stand for hours trying to convince this person why I should, but if the ethical mind shift switch hasn't taken place in his mind or her mind, realizing that this is the responsible thing to do for the future, especially as we know with millions of dental implants being placed every year. So, yeah.
So you said something very profound. I agree. Studying epidemiology is profound. Explain why some of your viewers might not really understand what epidemiology is, but explain what epidemiology is, and why did going back to school studying epidemiology, how did that change the way you think?
Well, look, epidemiology is the study of disease and all the factors around it leading up to it. So, you know, let me give you a very practical example for interpreting randomized controlled trials. You know, so one of the modules, let me backpedal a bit. Most colleagues, most people think that just because something is published in a journal, that is the truth. You know, and as you and I know, that is definitely not the case. So, for example, one of the modules that we did would be how to evaluate a randomized controlled trial. You know, and if you know that, 3 easy steps. First of all, you look at internal validity. You look at internal validity. It means what have the researchers actually proved what they meant to prove in the beginning, and that would mean have they proved what was in their protocol, and there are a whole list of biases to go through in order to check that. And you know, sometimes when evaluating a randomized controlled trial, after running through all those biases, you might find that there's initial biases, and we're talking about selection biases and blinding of studies, and that it's not even worth carrying on to the next step to look at the results. If you feel that your internal validity is good, then you'll move on to the next step, which is results. And then interestingly, you know, you look at many randomized controlled trials, and they are actually reported on mostly in relative risks. Whereas a much more effective way to see whether something fits into your practice is to work out the numbers needed to treat, which is, you know, so if we worked out numbers needed to treat, and we say, okay, Howard, you know, in the end, you have to treat 115 patients with a new composite material in order to reduce micro leakage by 3%, then that is something relevant to your practice. And you can say, well, you know what, for me to switch over to a new composite, already using the one which is comfortable in my hands, I'm quite happy staying where I am. So numbers needed to treat is a more practical way of bringing the results of research into your practice. And then the third thing would be external validity. Can I take the results of this trial and can I bring it into my practice and use it? So, you know, that's just one module relating to the critical appraisal of randomized controlled trials. Whereas before I did these studies, you know, I didn't have those skills. I would look at the results of an article and sort of just accept them for what was being told to me, you know. So that's an example, and it's been an eye-opener to me. To me, it's been the most valuable thing that I've done in my professional career.
That is so cool. Going back to school is so amazing. You know, I always thought the periodontist and implantologist should take a page from the endodontist just from practice management. The endodontist, when they finish a root canal, they always say to the patient, they need you to come back 1 year later for a post-op x-ray to make sure everything healed. And it's a great scheduled thing to see your follow-up, did it work, to build your relationship with your patient. And I think everybody in implant dentistry should just say, you know, in order for me to warranty this, I warranty everything, I do 5 years. And I say, in order for me to warranty this for 5 years, I need to see you at 1 year for a follow-up x-ray, because sometimes at 1 year, you might need to do something that would prevent it from failing at 5 years. And your car, to have the warranty on your car, you have to get the oil changed every 3,000 miles, or the dealer will not warranty their work. And it's a chance to see if your implants worked, build a relationship with the patient. A lot of times they're ready to move on to replacing another tooth with another implant. And there's so many features that I love about what you've done.
Yeah, you're 100% correct. And as you know, I think the most important thing in dentistry in our profession is communication. And you know, you might see a patient for a follow-up after a year or two, and there's a little bit of peri-implantitis developed, or just some peri-implant mucositis with some overt gingival inflammation. And they say to you, doctor, I didn't realize I had to come back. So we've then fallen short in our communication. But with our system, and you talk about the follow-up and the servicing of an automobile, I mean, this is exactly what we're looking at here. You're selling a person a new automobile, and then you don't just leave them till black smoke starts coming out somewhere. You have your service booklet, and they have to pop in every 10,000 miles. We're obviously talking kilometers, and it's important that they don't miss that. So that, and they pick up little things, change little things here and there to keep that car running efficiently and smoothly as possible. So that's the same thing with findmyimplant.com.
So talk about the implant situation in South Africa, because we know some countries like Korea and Germany, 3 out of 4 dentists placed an implant last month. We know in the United States that in my 30 years, you know, the first half of my career, the oral surgeons and the periodontists placed about 80% of the implants. And now, as of just last year, 2015 was the first year, the general dentists placed more than 51%, and the oral surgeons and the periodontists placed less than 50%. How many dentists are in South Africa, and what percent would you say place dental implants?
Look, we've got about 3,500 to 4,000 dentists registered in South Africa for a population of over 50 million. So you could say we are short on dental manpower. If we look 20, 25 years ago, 30 years ago, the pioneers in dental implantology, which was at that time a new discipline, and as you know, you get the pioneer clinicians for new technology, and it's normally specialists. So at that time, we had periodontists and maxillofacial surgeons starting to place the first implants, and in this country they were mainly Brunnermarks, the pure titanium Brunnermark external hex implants, and there were also the old Corvents and Calcitex which were placed. That status quo of implants being placed by periodontists and maxillofacial surgeons has stayed stable, but in relative years, things have started to change. And when I say that, there are many more general practitioners placing dental implants. I think what you find now is that the new graduates coming out of university many of them are going into place their own dental implants. And now we also see a situation where there seems to be many more prosthodontists placing their own implants as well. So at the moment there's a little bit of what would the word be? Not bad feelings, but in the dental politics, you know, this protection of your discipline and who should be doing what, you know. So yeah, but that's been an interesting development. Definitely more general practitioners, so then placing implants and restoring implants, and more prosthodontists placing implants.
Yeah, and you've been big in your dental society. Does that because you're just a glutton for punishment, or what made you want to get involved in South African dental politics? I mean, they always say that you couldn't get two dentists to agree that today is Tuesday, let alone anything else. What's that like getting involved in South African dental society politics?
You know, I think it's like anywhere else in the world. Like you said, to get two dentists around a table to agree to something can be quite a thing. A glutton for punishment, probably, without a doubt. Like, you know, I think to be honest, us as dentists working in our little areas, often going home to families, to spouses who don't realize what we go through every day, the stress we're involved with, and you also don't want to go home and just blurt out all these things that have given you a stressful day. So I personally always enjoy going to meetings and meeting my colleagues. I enjoy that collegial fellowship, being with people who have gone through the same thing every day. They understand who you are, what you've done, and I think from there on, you know, one sort of after a while sort of gets roped in to do a little bit of admin, a little bit of dental politics. So,
yeah, and that's why I started Dental Town in 1998, because you don't always have those meetings, or you know, you want some of that camaraderie right now. But I want to tell you, on Dental Town, there's 250,000 dentists from every country on earth, and when you make a post, you can go to that YouTube video where it says share. There's a link. You can post that link, but one of the shares is embed. So you click embed and you pick up that code and you drop it into the comment on Dental Town, and your YouTube video will be in there. And there's 50 categories: root canals, fillings, crowns. But you should go to Dental Implantology forum on Dental Town and drop that YouTube video in there, because I think what you're doing is amazing. You and I, how long have you been practicing dentistry? How old are you, and how long have you been doing this? Because you got out in 89. I got out in 87.
I'm 50 years old.
You're 50, I'm 54. So what would you say after 30 years, what would you say to a young kid listening to you right now, a young 25-year-old dentist, and she says, there's so many implant systems. You've been doing this for 30 years. You see all these implant systems logged on findmyimplant.com. Help her make a decision. If she wants to learn how to start placing implants, which system would you recommend and why?
Well, before one talks about systems, there are many. There's a multitude of systems out there that work well. And you know, if you have to talk about survival rates relating to dental implants, if you go to the Cochrane Library, there's a big study which looks at hundreds of implant companies, and their conclusion is that there's no one company specifically which has got any major implant survival rate above another. So to me, it's more about if you're deciding to do something new, like placing dental implants, I think you should identify, you as general practitioner have a referral network you work with. And if you decide then that you'd like to start placing dental implants, my advice to you would be to approach the specialist or general practitioner with a lot of experience, discuss your decision that this is what you'd like to embark on, and then work with that person for a while, gaining experience, and then letting that person work with you in a few cases, and before you actually end up going out on your own. I think that too many people who start off wanting to do dental implantology, they feel that they'll just go to one of the company teaching programs, and buy a kit with 50 free implants, and now they're going to start placing implants. And I think if I was a patient and you're a patient in that scenario, I don't think you're too happy if you get a minor complication or something and you find out, well, this was this person's second or third implant. So to me, I think that's imperative, that the way you get involved, and then you asked about different implant companies. There are so many different implant companies out there, and we're talking about most of them having great results, and a lot of that is what works for certain practitioners. If I've been working with certain implant companies for a decade, even more, and you get used to that from a clinical point of view, But I always also so friends of mine who are implant reps, I always say to them, please don't go around to colleagues' practices and with the approach of, I've come to show you something which is better than what you're using. Go there and just say, look, I'm here to introduce my product. There are one or two new designs or new concepts which you may not have seen, where they're not present in the system you're using, and let me just show you and discuss that. Unfortunately, we have colleagues who are sort of not too keen to see any other reps than implant companies that they are placing. But myself, I'm always keen to look at other companies and look at other innovations they've come up with, because your one single company that you're working with can't think about the multitude of options, being it from fixture placement to abutments. So it's. But my advice in general, while we're talking about younger colleagues, would be to be looking after yourself physically, emotionally, and spiritually, because it's a long haul, and this profession of ours can be a killer if you don't watch out.
Back to your background in epidemiology, is one of the problems with implant success rate? I mean, there's a lot of bizarre selection. I don't know what you call that. In the fact that in my practice in Phoenix, the people that need the implants the most are most likely not to have the same home care and quality of teeth that you and I have.
Yeah.
And so, when, it must be hard to kind of figure out an implant survival rate when you're placing an implant, some 68-year-old man who's already lost half his teeth from periodontal disease. And when you lose half your teeth from periodontal disease, it's not like you're a great brusher and flosser and doing everything right. So I almost think that you're absolutely right, that the success of an implant probably has a heck of a lot less to do with the implant and 100 times more with your patient selection.
Indeed, there's no doubt about that. I mean, but you and I know that what are implant companies driving towards? They're continually driving towards developing products to draw in more and more compromised situations, aren't they? trying to enhance surface characteristics, so that or they're trying to use thinner implants, or they're trying to use shorter implants to include that ridge below the sinus area, or an area in the anterior maxilla where the patient might not be interested in any bone grafting, or the patient's a smoker and they don't want to do any bone grafting, but they still want to try and get an implant in. So companies are continually pushing that envelope, and if we had to just, I think that's the nature of the beast, if we had to just select absolutely the ideal cases all the time, we definitely would I think if we're honest with ourselves, we definitely would place less implants. But yet, even in situations where there is some systemic risk factors, where there's smoking, or there's a little bit of type 2 diabetes, or plaque control is not as it is, we still actually get some good results and are able to give people teeth. I know there's a colleague of mine who works in Greece, has a very successful practice, and he says if you had to not place implants in anybody who smokes, he wouldn't have an implant practice.
Right.
And he has a high success rate, so. Yes.
Right. It's you go to some of these classes and they start telling you who's not a candidate for implants, and you said, okay, I'm going to go home and close down my practice.
Indeed.
And I
Indeed.
also wonder about that with some of these great cancer hospitals. You see so much in the media that the great cancer hospitals in the United States, like Mayo Clinic or John Hopkins or the Houston place, has a 5-year survival rate of about 10% higher than the other hospitals. But then you start looking at the patients that can afford to go to the Mayo Clinic or fly to John Hopkins versus your county hospital, where you have a lot more poor, a lot less educated, a lot of people who have less money and access to better vegetables and nutrition and eating, and you start playing all those factors on, and then you wonder if there even is a difference.
Indeed. Just on that point, there's an American author called Atul Gawande, Atulgwande, and he writes a lot of medical nonfiction. And I was reading his book the other day on checklists. It's called, I don't know if you might have read it, it's called The Checklist Manifesto, Avoiding Complications. And it's actually, it's all about surgical checklists, which he had put together, and it's actually been adopted by the World Health Organization in 2006, which have been brought into theaters. And just from these checklists, they have been able to reduce all over the world. They did a multi-center pilot trial. They've been able to decrease complications by about 50%. And these are such interesting and basic things. For example, introducing the whole team, introducing themselves to one another. Simple things like that, which have resulted in these decrease in complications. I don't know why I brought that story up, but
well, I just found the book on Amazon.com from my lovely associate Ryan Ferran. Thanks, Ryan. Yeah, it's called the Checklist Manifesto by Atul Gawande, Atul, last name Gawande. So you recommend reading that book?
Oh, indeed. Indeed.
Are you gonna place that? Are you gonna post that your YouTube video on Dental Town under the implant in the implant section?
Yes, I will indeed.
Yeah, I will post this book too. What is do you give out email to our listeners, or would that drive you crazy?
Yeah, of course.
What is your email?
My email is I'm going to use an easy one. It's Paul, Paul, at sasa.co.za.
sasa.co.sa. Oh,
ZA. That's it.
Why is the internet email for South Africa ZA instead of SA? How did that happen?
Oh,
Is it
that's
German or Dutch or?
from Dutch. It's actually Zuid-Afrika. ZUID Africa, AFRIKA. So it's a Dutch name.
Well, I'll tell you, I lectured in South Africa this year, and I took two of my four boys, Ryan and Greg, and oh my God, we had a blast. That country is so beautiful. I mean, it's just
It's lovely.
stunningly beautiful. We didn't get to see Cape Town. Hopefully, before I die, I'll lecture in Cape Town. But my gosh, Johannesburg, Soweto. We went on a couple of game.
Yeah.
What do you call
Well,
those reserves?
game drive. Game
Yeah.
drives.
What an
Yeah.
amazing country. So what again, you and I have been doing this for 3 decades, and people who listen to podcasts are usually under 30. So old guys like you and me, we read books and go to dental meetings. The young kids
Yeah.
are online, audio books. What more advice would you give if to a young kid who says, I want to get good in I want to learn how to place implants and start getting um, good. Do you draw blood? Are you centrifuging blood? Are you big into that or?
No, I'm not.
Yeah, it's
Um, if you can, let's talk about getting into your first part of your question was getting into, say, dental implantology. You know, when in my postgraduate program over 20 years ago, you know, um, we didn't have the type of instructors that we have now because everybody was sort of going through this learning curve. So, I mean, at that stage of my career, I was like a sponge. You know, I said to myself, I have to attend everything and anything that's being presented on dental implantology. Um, I have to consult with all friends or colleagues that I have, um, and 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 that is the only way to go about it. You know, you cannot expect to get involved in the discipline by merely attending a one-day course and thinking now that you're going to be clinically involved in placing implants. The one bugbear I have as well about dental implant reps is that they're often into surgeries, looking over their shoulders, um, and sort of giving them surreptitious instructions on, you know, keeping a drill more parallel, or let's go a little bit deeper. You know, to me, it's totally unethical, and it's definitely not the way to go about it. Coming back about centrifuging blood and doing all that stuff, I generally try and look at doing my implant cases with as minimal bone augmentation as possible. So I use it a local company, Southern Implants, where we've got a presence in 13 different countries around the world and in North America. And they have got, for
what's the name
example,
of the
implants,
company?
Southern Implants.
And that's for your implant, Southern Implants. That's the name of your implant, and what else? And the bone grafting.
So if you ever look at the Southern Implant, they've got a concept that was designed by a South African prosthodontist, which is called a coaxial implant. So the concept of a coaxial implant is that the actual top prosthodontic platform is at an angle, 12 degrees, 24 degrees, or 36 degrees. So for use in areas, for example, the anterior maxilla, where there's a slight anatomical undercut, you can place the implant, and the prosthodontic platform has already got this built-in angle. So it allows one to do less bone grafting. It allows one to do screw-retained prosthesis without the stacking of extra abutments. And because of the angle of the prosthodontic platform, you can also place it at an angle under an antrum, thereby avoiding many sinus augmentations. and they've also got wider, shorter implants. So by using these new technologies that Southern Implant have, one can often avoid having larger bone grafts, and then if I do require something that is more extensive, then I will call in one of my colleagues to assist in the case. I'm not someone who's afraid to. I learned a long time ago that in your clinical life you draw a line under certain things which you don't do very often, and rather for the patient's sake, because that's what it's all about, isn't it? Bring in someone as a part of the team.
You know what's you know what's so hilarious? I'm on their website right now, southernimplants.com, and when you're a guy like me and you're always going to all these dental implant or dentist websites or dental manufacturing websites, almost no dentist on earth puts the name of their country on their website. Like the address for this company says 1 Albert Road, Irene-RSA. And so what I have to do is I have to take the area code. The area code is +27, and then find out what damn country is +27. What country is this in?
South Africa.
Oh, it's in South Africa. Yeah. And so if you're listening to this, it's confusing to dentists around the world when you just say, "Oh, I live in River Springs." It's like, well, how many countries? How many countries have a city called Springdale or Two Rivers or whatever? But yeah, so you like that? So that's your favorite go-to implant, SouthernImplant.com?
Indeed. So this coaxis concept is, it's just something really mind-blowing.
And who started this company? You said it was a prosthodontist?
No, it's a bioengineer called Graham Blackbeard. Graham studied engineering in Cape Town and then studied bioengineering in the United States. And he started off in 1987. So it's a privately owned company.
That's the year I graduated.
Yeah, and he's got subsidiaries now.
And he's still alive?
Indeed. You
want to know how old I am? When I first learned implants and we needed a CAT scan, we would just call in a cat to just sniff around on the patient. That was the only CAT scan we had. Have you noticed another change in implants? When you and I were little and got out of school, the goal of an implant was to have the longest implant possible. Everything you were trying to do is just make it the longest possible. And now you see a lot of implants going shorter and fatter. Have you noticed that trend, and what do you think of it?
Well, I do use a lot of short implants. So if you say short implants, for me, that's anything under 10 millimeters. So I do use a lot of 8 millimeters and even 6 millimeter implants. With a shorter implant, like a 6 or an 8, I'd probably do a 2-stage procedure and a little longer healing time. I think over the years, everybody tries to push healing time to get things going as quickly as possible. But in certain areas, in posterior maxillas, where the bone is definitely softer, and if you're working with a more restricted vertical height, my philosophy now is, time one can't buy. And if we have to wait an extra month or 2 months, then so be it. Yes, so Southern Implants have got 5 different connections. So recently I've been using a lot of internal octagon connection and placing an implant in an area with minimal bone just subcrestally, and that placement gets the growth of the bone over the shoulder of the implant. And yes, I've been having great success with it from that point of view. But you're right.
I'm so excited about that trend, because usually anything short and fat like me is bad. So I'm glad to see that short fat implants are a good thing. I want to ask a couple of the most interesting thing I see in implants is all my older friends that are from 50 to 75 that have placed over 5,000. They never use surgical guides, and all the young people who have placed 50 and under do place surgical guides. What's your view on surgical guides?
Well, I've always thought I did my first surgical guide case through the company MIS from Israel, Make It Simple, which, and I did that about 6 months ago. It worked like a bomb. But before that, I've done everything brain guided, as they say. And after doing my first guided case, I thought to myself that this was something that I could incorporate into practice, but I still haven't. So I've got a cone beam CT scan. That's another thing, obviously, one can talk about is the increased use of cone beam CT. So with me, the use of the cone beam CT has really improved the amount of time that I take with procedures, lessened the amount of time. So if I'm doing a full upper edentulous arch, do the CT examination and start off taking my measurement 6 millimeters left and right of the midline, saving those images, having them at surgery, and knowing exactly the depths that I'm going to be drilling means I can open a flap and place the implants quite quickly and effectively. Yes, with minimal complications. So the one thing that is really sort of improved my experience of placing dental implants all these years has been cone beam, without a doubt. The question then obviously is, are we moving towards a scenario where cone beam becomes standard practice? I think if you're looking at placing implants in the posterior mandible, and you have a possible paresthesia, and someone says to you, why didn't you use cone beam? You've got it, it's available. I don't think you're really going to have the foot to stand on, So I think in certain parts of the mouth, the anatomy, especially posterior mandible, I think if you've got it, you should be using it, But not for everything. I know some people do use it for every case they do, but I don't think we've got there yet.
I want to ask you a philosophical, personal question. The United States, 13.5%, there's 324 million people here, and 13.5% of them live below the poverty line, which is 50 million people, which is the total population of South Africa. And sometimes I see people taking the poor person's all their money to restore 1 second molar, an implant and a crown. And I have a bias. In my 30 years, I've never removed anybody's wisdom teeth that were in occlusion where they came back and said, I miss chewing on that. On a second molar where they couldn't afford the root canal or whatever, or for some reason had to be pulled, only one person per decade has ever came back and said, yeah, I really miss that tooth chewing on. So my question to you is, when you're dealing with someone that doesn't have a lot of money, do you really think they should spend a year's budget on a second molar, doing an implant in a crown or a root canal in the crown, when that money could have been used to fix like all 8 of their cavities with fillings? I mean, do you ever say to your patient, I wouldn't spend all my money on a second molar when you could be spending money on teeth that are more functional, that you see, cosmetic, chewing? So what's your view on a second molar?
So I couldn't agree with you more. If I have to remove a second molar and the patient has sufficient function, I mean, if we talk about what is sufficient function, there's a lot of research out there which shows that a 5-to-5 occlusion has the same type of function as a full 28 teeth. And I think they use measurements like chew through time, for example. My advice to the patient is, we'll remove this tooth, we'll let the area heal, and you'll see how you function. And I'll tell them, what you're probably going to find is that you're functioning quite adequately, and that we don't have to spend all that money to replace that second molar. And you touched on something which is also close to my heart, is that, as technology progresses and as time goes by, technology should be becoming more and more affordable for more people. And unfortunately, I find in the areas where I work, I see some quotes for replacing a single tooth is just so astronomical. And I think what happens is a lot of people don't go for a second opinion, and then they end up not having the advantage of implant treatment. So but yep, I agree with you. I couldn't agree more with you.
Yeah.
So I'm not a good salesman when it comes to that type of thing.
Yeah, we're not good salesmen, and I don't think doctors. I mean, and that's not always a bad thing, you know.
Indeed.
So, um, we talked about surgical guides. We talked about second molars. We talked about CBCTs. That drawing blood, though, I want to go back to that because when I talk to some of the dentists who place the most implants in the world, like Carl Mish,
Yes.
he says, I don't care if they smoke. He goes, smokers are the ones that need most all the implants. I mean, they smoke. You know, he says,
Yes.
I don't even care. And he also doesn't he thinks the drawing blood and the platelets and all that stuff. He doesn't think that's necessary either. Um, and you agree with that or?
You know, I do agree with that. And so coming back to the epidemiology story, I feel that there's not enough long-term randomized control trials to actually show in split mouth designs um, the improvement of one area that's better off using all the drawn blood, etc., compared to other sites. And what we have too much of, I think, in our profession, if you look at epidemiology, they look at levels of evidence. So your best level of evidence is a systematic review of randomized controlled trials. Under that would be just a single randomized controlled trial. But right at the bottom, the poorest type of information is expert opinion. So expert opinion is me as a general practitioner. I want to find out about this product that this rep has come and shown me. I phone up the road to my specialist colleague and friend, and he says, "No, yes, I use this all the time. It's fantastic." And then because of his status, I believe that. But it's only expert opinion, and it's the worst type of evidence one can have. And we have too many situations around the world where we have so-called experts up on stages providing only their best cases and telling us that this is the way to go. They're sponsored by companies to be there and to give these results. I would like us to move into and I do see some organizations do try that, to move into a time when someone gets up on the stage and show us their worst and their best together, and then speculate, talk about how we got to the one and how we got to the other one. That to me is a learning curve. And the other day I was at a meeting here in Cape Town with a young colleague who had been placing dental implants for probably less than 5 years, and there was someone up on the stage. And he was making one or two statements which I thought were not based on real good evidence. That's expert opinion, low evidence levels, and I could see that this young colleague of ours was sort of buying into this. I could see that this was something that she was probably going to take into her practice, but was not based on good high levels of evidence. And to me, I found that very disappointing. But now I think I've taken a little bit of deviation again. The other thing I think in dentistry is that we need, from a research point of view, we need more patient-reported outcomes. You've seen lectures on stage where fractions of millimeters of the zenith point of gingiva are compared to one another around implant crowns, and then it's worked out. Then they work out that this technique possibly is a little bit more advantageous than the other, but that is a clinician-reported outcome. But the important person is the patient happy? And we don't do enough studies with patient-reported outcomes. I think there's an interesting, there's a very interesting survey stroke questionnaire done in 2000, published in 2011 from an Austrian group of patients, where they asked patients about bone grafting, and they asked them about costs of implant treatment, and then one or two other things. And it was so interesting to hear their feedback. For example, what came out of that was that as soon as patients heard about bone grafting procedures that had to take place, there was a lower acceptance of treatment plan. Now this is the type of feedback we need. There's a young colleague of mine doing also the same clinical epidemiology course that I'm doing, and we were talking about a research project which is part of the study. And I said to her, what, I think you should copy that Austrian study in the South African population. It'll be the first time in 25 to 30 years that we then, as South African clinicians, will actually get some feedback from the patients and from how they've been experiencing dental implantology. We can't just go on in the dark without hearing from our customers.
And speaking of hearing from your customers, Paul, I want to ask you another philosophical, personal question. Sometimes I believe that since we're dentists, we worship teeth. And I've seen so many implant cases, sinus lifts go south. And, they did a sinus lift, they bone grafted it, they did all this crap to the sinus. And there were 2 teeth there. And my friends in town that are ear, nose, and throat or rhinologists, they're sitting there saying, what the hell? You had 2 perfectly good teeth there. What did you go blow up the whole sinus for? And sometimes I'm looking at the cost and the craziness and all this stuff and tell the dentist, like, and their wording, they say, well, I don't want to file down 2 virgin teeth. I mean, that even sounds like religion. They don't want to sacrifice a virgin. So they're ready to just blow up the whole damn sinus, fill it with all this crap, and then when it goes south. So what do you think about that? Do you think there's a lot of shaming amongst dentists who file down a second bicuspid and a second molar for a bridge, and are like, oh, come on, you're a hack. I'm an expert. I did a sinus lift. And it's like, okay, well, do you see that shaming? I mean, I've seen people refer to people as hacks that do 3-unit bridges for over a sinus.
I do. I see no reason. But remember, we have to discuss all the treatment options with our patients. Often a patient is referred for possible implant placement, but they haven't been given any other options yet. They're under the impression that there's only one option here. I've got a missing tooth, so I've got to have an implant. And I think we all too often forget about other dental procedures and options which are available. So I'm 100% with you.
And with the poor, I do a procedure that I don't even think is legal, where it's a 1-tooth partial with 2 claps. And a lot of dentists and labs say they can't make that because the patient might swallow it and gag and choke. And it's like, oh, are you kidding me? That when I've made those for people that didn't have the money, they love it. It's just 1 tooth, clasp on each side. It replaced the missing tooth. I've never had a person swallow it. I never heard some of the dentists say, well, what if they're sleeping on their back and it falls out and they swallow it and choke it? It's like, I've never seen this, but even that is an option.
Yeah, of course. And once again, it comes through communication with your patient. I think you're talking about those little Velplast dentures that are made. Absolutely. There's no doubt. There's no doubt about it. That some people feel if there's a gap and they can't fill it with an implant, then they're a failure. And my training as a periodontist, and when I started that in 1996. We were starting to do implants, but I, as a periodontist, I've learned to do all those, and all those procedures to try and save teeth. Distobuccal root resections, hemisections, apicos, crown lengthenings. In those days, we did almost everything to try and save a tooth, especially an anchor tooth, because there wasn't anything else. And sometimes I feel my referral network, younger colleagues, they don't know about these options. They haven't seen them, whereas you and I have seen how these options after 20 years are still working 100%. And as I tell them as well, it's easier to maintain plaque control around a tooth than it is around an implant. We know that. So if you've got so one thing, I mean, I spend, I think, really, if an upper 6 is the last tooth in the arch, and there's periodontal sickness involved and loss of bone, I try my utmost to save that tooth. I would do a root canal treatment and then do a distobuccal root resection and create a healthy, solid 2-rooted tooth out of a diseased 3-rooted tooth. And those things, they last decades, whereas if you, we have the situation, I don't know if you have experienced the same situation in America, where we'll have generalists and maxillofacial surgeons just look at a panorex and see bone loss and say, without getting a proper clinical evaluation, say, these teeth are not going to last. Let's do a clearance and we're going to do implant treatment.
Right.
To me, which is so sad, because in many of those cases, the patient will come to me for a consultation, and the first thing I ask them is, excuse me, how are you functioning? And although they have mobility and they have much inflammation, they're functioning well. So then obviously it's an obvious thing that if you do an initial full mouth disinfection with scaling and root planing and possibly remove some of the terminal teeth, that situation is going to improve, vastly improve, and being on a regular 2-monthly dental hygiene follow-up program, they can maintain those teeth and possibly then bring about a few extra cosmetic changes to close a diastema here or there. But that's also a bugbear for me. I think there are too many people out there losing teeth as a result of inadequate periodontal examinations, diagnosis, and treatment plans.
But it's gotten so much better, because for me personally, where I grew up in Kansas, I didn't have any grandparents, great-grandparents, or uncles that had one tooth in their head.
Yeah,
I mean, it was, and almost all of them,
yes.
got their teeth fixed up for their wedding, so they got their dentures usually before they got married. I mean, they were getting their dentures at 16, 17, 18. So it's come a long way.
The blood vulcanite era.
So thank you so much for coming on my show. I hope you post that Find My Implant video under Implantology on the Dental Town forums, because I think my homies will really appreciate what you've done. Love your country. Hope someday I get to see Cape Town. I hope it's half as beautiful as Johannesburg and Soweto. Just loved it. But I just want to tell you again, thanks for coming on my show. Thank you for all that you've done for dentistry. And I hope I didn't keep you up past your bedtime.
Oh, not at all. From my side, thanks for having me. It's been a real great experience chatting to you. Yes, just thanks very much.